Hi, welcome to the Orthobiologics Podcast. I'm your host, Trevor Turner, MD, RMSK with Georgia Bone and Joint and the Center for Orthobiologics. Welcome to our fourth episode, which is called A Shoulder to Cry On. In the episode today, we have the privilege of speaking with the esteemed guest, Dr. Siddharth Damber, who is a rheumatologist by training. He works at the Chicago Arthritis and Regenerative Medicine Clinic. He's going to share his expertise with us today on all things shoulder. And with that, I just want to start with asking him, Siddharth, you as a rheumatologist are probably one of the few MDs out there in your specialty who have really dedicated their focus to biologics and regenerative medicine. To me, it seems like a natural fit, but tell us a little bit about why you got into it and talk with us about your practice pattern.
Yeah, that's a great question. First and foremost, thank you very much, Trevor. Really a privilege to sit down and talk and chit chat about regenerative medicine and orthobiologics, such an exciting and interesting space. So my privilege, and thank you very much. So, my original training is in clinical rheumatology. And in my last year of fellowship, I attended a musculoskeletal ultrasound course. This is back in 2007. And I knew nothing about ultrasound at that point. It was something that was being used in Europe, very little here in the United States. And I checked it out, having no clue what it would be. And it really opened my eyes to anatomy, musculoskeletal anatomy, in a way that I really hadn't thought of it before. The shoulder ultrasound in particular is such a great use of ultrasound. And it just really opened my eyes to just how intricate and nuanced and sophisticated and three-dimensional the anatomy is in the body. And it kind of got me excited and interested in a lot of tendon-related issues. And so as I started attending more and more courses, I remember one particular course, cadaver-based injection course, where I heard two other physicians talking about platelet-rich plasma, somebody else talking about prolotherapy. And I'd never heard of any of these things back in 2007, 2008. That was brand new to me. That was still relatively new, PRP, in terms of its use in this country. But that was really the start for me, where I said, what am I missing here? What else can I learn? How else can I treat better tendons and other kind of issues that I don't think are getting treated very well with conservative or typical care? And that really shot me down a totally different rabbit hole. At that point, there was very little out there on platelet-rich plasma. And I really hustled as much as I could to learn more, reading everything that I could. I found a listserv that was really primarily only for board-certified sports medicine physicians. I somehow talked my way to be allowed on that and just started blasting them with questions. I really had no clue what this was about. And so I just got into it from a learning standpoint, just really excited and open-minded. When I started practice in 2008, I bought my ultrasound machine, would scan everything that looked interesting, and just slowly, progressively started introducing platelet-rich plasma into my practice. As I started getting more and more experience with that, I started expanding into other types of orthobiologic treatments and started learning more about even traditional prolotherapy methods and the value of that. And so I really got interested in this primarily from ultrasound, having no idea what I was walking myself into. And the way these kind of orthobiologic treatments work is that as you learn more and as you start applying them more, you just get further and further down the rabbit hole. And so that's sort of how I originally started off with this.
Siddharth, I really just appreciate your description that, a lot of ways ultrasound was your foray into this world, because I remember the first time I was taught to do injections by a very old school doc who was a great old sports medicine doc. He'd seen a lot of pathology and he was teaching us what we call landmark guided injections, meaning, for patients out there, that means, you're injecting something based on kind of a map in your head of the anatomy. And then when I really started to learn ultrasound, it really showed me that some of the techniques maybe we were taught originally were not as accurate or as predictive at getting our desired result as we thought. And so, Siddharth, tell me about, we're talking about shoulder. How many times do you do a diagnostic or maybe a screening ultrasound looking at the joint or the rotator cuff before you end up planning an intervention for a patient?
Yeah. So, first and foremost, to me, if you're a musculoskeletal expert, ultrasound is really our stethoscope. Meaning, I don't need a stethoscope to listen to the heart or the lungs. That's not my field of expertise. But I need a tool that lets me look at the tendon, the joint, the ligaments in a static as well as in a dynamic way. And to me, ultrasound is that stethoscope. So I use it in a lot in terms of diagnostics. For me, I think even looking at a partial rotator cuff tear, ultrasound, I think just offers more sensitivity in terms of finding some of the smaller areas that are actually torn than even MRI does. So I use it a lot in shoulder patients because I think there's so much value in terms of really targeting where the actual pathology, where the actual problem is. And I think it's pretty common that as you're scanning and somebody says, yeah, that's where my pain is, and you quickly scan, and you go, oh yeah, well that's where that's what your problem is. And so I use it quite frequently in terms of diagnostics for shoulder issues.
And you used a word that maybe not every listener or every patient may be familiar with, and you said dynamic. Will you expand upon what you mean when you say you do dynamic ultrasound?
Yeah, so I mean, essentially, a static image is like taking just a picture with your camera, while a dynamic image is essentially a video of that same of that same scenario. And so, if you take something like the shoulder, you can look at it with some static images, and you can see where pathology is. But the reality is, when you're looking at tendons, as you put somebody through range of motion, resistance, passive range of motion, active range of motion, you can see what the stress is on that tendon. You can look at ligaments and you can see how strong they are, how weak they are, how lax they are. You can compare it to the other side if it's normal. And then actually get a sense for how abnormal the other side is. So the dynamic nature of things is what really makes ultrasound shine in a way that is hard for MRI to do because it's very rare to get a dynamic MRI. So to me, that's one of the really great strengths and advantages of ultrasound for sure.
Yeah, I just totally agree with that. And I think, there's so many people who come into the office and they think, well, unless I've had an MRI, I'm not going to be able to see what's going on. And they're shocked, especially in the shoulder realm, when we can perform dynamic ultrasound for them and say, look, I'm going to show you things that, sometimes you will not find on an MRI. And it's actually going to totally change the way that we treat you and how we help you get better. Siddharth, you had mentioned rotator cuff a little bit earlier, and you were talking about tears, and we see all kinds of varieties of tears, whether or not they're traumatic or whether or not they're degenerative, and whether or not they are full or partial, and what part of the cuff they're on. Can you talk a little bit about how do you use prolotherapy? How do you use PRP in the context of addressing a rotator cuff tear, and maybe also what else even besides those two options would you consider?
Right. So I think when it comes to rotator cuff pathology, first and foremost, obviously defining what's the severity of the injury is important. There's clearly certain types of injuries that are better served primarily by surgery. There's some evidence that you can augment surgical repairs with bone marrow aspirate concentrate. So there is some advantage to using orthobiologics even in that setting. But I think if somebody has a partial tear, in addition, if they have a full thickness tear, but where the ends of the tendon are basically still approximated together, where they're not pulled apart and retracted, that can still be treated. But prolotherapy helps in terms of treating more laxity as well as ligamentous instability. Platelet-rich plasma is a good option if you're talking about a partial thickness tear. A mild partial thickness tear and bone marrow derived stem cells is generally a better option if you're talking about a more significant partial tear or even a limited full thickness tear as well. So depending on the level of pathology, that's generally how I would pick which orthobiologic I think is appropriate.
And so, Siddharth, would you consider yourself protocol driven? I mean, do you tend to go through a reliable progression of treatment options, or do you tend to focus on just the severity of the initial lesion and say, okay, let's go for the big guns, let's go ahead and use the most powerful treatments that we have?
Certainly you have to go through stepwise process, right? I mean, so if someone comes in with a partial thickness tear or a chronic tendinopathy of the tendon, absolutely, have they at least failed some conservative options, right? Have they gone through the usual sort of process, meaning activity modification, physical therapy, some over-the-counter supplements? Have they tried all those kind of things before you start jumping into injections and treatments like that? While these treatments are low risk, there's nothing that's no risk, and so make sure someone's actually kind of progressed through those kind of things before you're actually kind of progressing. After that, I generally end up using more platelets probably than anything else, in part because I think that helps for a lot of things, and also in part because I think it's a good first step before you jump to other things. There's certain types of injuries, maybe severity of a rotator cuff, where I think it's better served with bone marrow. The data for post-surgical treatment is really with bone marrow rather than PRP. And so I think that makes sense in that regard as well. But certainly taking that kind of stepwise approach before you start jumping into any kind of procedure.
And then, you mentioned augmentation of rotator cuff repairs. And, for us, we're an orthopedic group. So I would say, a significant percentage of the biologics that we do are actually intraoperative. I know as a rheumatologist, your skill set is highly valued by sports medicine and orthopedic practitioners. Do you go to the OR with anybody, or are you referring to other orthos that are going to practice in biologics, or how do you address that gap?
It's interesting. I don't have a good bridge for that gap at this point. I think that is so dependent on the local politics, unfortunately. I think from a data-driven standpoint, if you look at what's out there, Philip Hernigue using BMAC to augment his rotator cuff repairs, and then comparing his patients that have had that orthobiologic augmentation versus his ones that have not, and seeing that the ones that were augmented did better long term in terms of reducing the chance of re-tear. I think that's such a sensible way to approach it. Don Buford in Texas has tried PRP in his rotator cuff repairs and finds that he hasn't had as good of a response. So to me, I think the value in terms of orthobiologics right now for rotator cuff repairs is certainly with BMAC. I think you have obviously an interesting probably prior experience with some of your with some of your patients, whether it's in training or currently. Do you find that you'll augment with platelets and that's a value, or do you find that really sticking with BMAC makes sense?
Yeah, no, I appreciate you bringing up actually the paper by Felipe Hernigo, and we did mention him on a prior episode, and in some ways sort of consider him to be the godfather of some of the orthobiologics movement, and his practice is based in Paris, France, but he really has such a long history of data collection, and so when I talk with patients about this, when we're consenting before we do a procedure like this, I'm telling them, look, we look at some of the other treatments we do in medicine, and it's very rare we have 10 years of data outcomes for people. I mean, when you have 10 years and a large volume of data, that's a very powerful study. So, because of that, we do, like when we do intraoperative rotator cuff repair, we very much do, prefer to enhance with BMAC, because basically that's where we feel as a group that the evidence is the strongest. However, I would say for people with partial thickness tears or with tendinosis, which we've mentioned a little bit on prior episodes, but that is kind of like the thickening that you get in a tendon that is kind of chronically scarred and maybe dysfunctional, but not fully torn. So we do tend to use, I would say, a lot more PRP in cases such as those, with good results. And we are keeping functional outcomes data for our registry. So I think that, we can be fairly, open about that. But the question is, going forward 10 years from now, it'll be interesting to see what, how the state of the science evolves. We have some guys I know here, for example, everything we're doing is autologous. It's all done with either a patient's own cells, which typically is either platelets or BMAC. Siddharth, do you have expertise in using grafts of any other kind? Do you use fat? Do you ever use umbilical cells or any off-the-shelf products or amnion? I've talked to different people who said they've tried that.
I am very heavily in favor of autologous cells. I think as much as you can use your own cells, there's just so much sense to that. I mean, your body reacts in a much more appropriate way. There is no risk of graft versus host disease. Some really rare reactions that you could potentially see in using somebody else's cells. The reality is for the off-the-shelf products, whether it's amniotic fluid, umbilical cord fluid, they don't have any live cells. Multiple organizations have looked at that, but they do have growth factors. They do have that extracellular matrix. For certain types of rotator cuff tears, if it's a more significant tear, I will combine amniotic fluid with either BMAC or PRP. So I think there's some value to that, even though there isn't necessarily a lot of evidence per se to back that up. That's been published, but I think it at least makes sense to augment. I don't like it as a primary treatment on its own. Meaning I don't like the idea of using amniotic fluid over platelets because I think you're getting a similar sort of growth factor effect. And in that case, why not use your own cells? I don't have a lot of experience with fat. I know right now fat is it's a challenge in this country if you're trying to make SVF or fat-derived stem cells. I think using it as a fat graft is a really interesting idea, and I think there's probably some value to it. I don't know of any really great data that shows that in a rotator cuff tear that it can add more than what we can do with just bone marrow or platelet cell.
So you used a word that I don't think we've actually discussed on the show before, and that's a fat graft. So Siddharth, what do you mean by that? What's that application?
Yeah, I mean, if you take fat, what's legally and regulatory allowed in this country right now is if you take fat, you cannot digest it with an enzyme called collagenase to break it down to a very high concentration of stem cells. The data for SVF, which is fat-derived stem cells that you can see a lot in places like South Korea and other parts of the world, is interesting and it's actually promising. It's not quite as it hasn't been around quite as long as, let's say, bone marrow aspirate concentrate, but there is some pretty good data that it can work. In terms of fat graft, that's more just taking fat, trying to rinse it off, and then using it to basically plug in an area that's actually been injured. It makes sense. I think it probably makes more sense for larger, let's say, muscle injuries or maybe hamstring tendon tears. So I think there's probably some value for it. Frankly, I don't know the exact right way to use fat at this point, in large part because I really have a lot more experience and expertise in using bone marrow and platelets. And the reality is in the orthopedic literature, that's still what sort of fills in most of our information.
Yeah, and I would say that's thank you for that explanation. And that's definitely something we've emphasized before is that, we look at the evidence of what we have available. There really is a large amount available on the use of bone marrow derived cells in particular, as well as PRP, especially an explosion of papers about that in the last 10 years. But there really, in comparison, is much less or there fewer data in regards to the use of fat. So let's switch gears for a little bit. We spend some time on rotator cuff, but you're certainly the shoulder is a complex joint. We see a lot of different kinds of problems. Do you really change the way you treat somebody when shoulder arthritis is the primary problem? And, does age or severity of arthritis play into that in terms of, I'm in my upper 70s and I don't want to get a shoulder replacement versus, I'm in my 50s. Talk about how you address arthritis of the glenohumeral joint.
Yeah, great question. So from an age standpoint, the data for knee arthritis, and that, I mean, it's different, but again, when you look at age, there is some evidence that age doesn't make a difference when it comes to pain and functional improvement, when it comes to using bone marrow aspirate concentrate for knee arthritis. Anecdotally, I think that's similar in shoulder arthritis as well. I think as long as somebody still has reasonable range of motion with their shoulder, I think there's someone who can still respond very well. The fact that it's a non-weight bearing joint, I think helps as well. I think really the key is to not only treat the shoulder joint, but really everything else that's driving pain. So really sort of downshifting into that prolotherapy thinking. Where are we treating all the ligaments? Are we treating all the soft tissue structures that also drive pain? It's not uncommon that when you have someone that has an arthritic joint, that as you're treating them, the areas that tend to have the most pain, whether it's a pain generator while you're actually injecting them, or even as you're just examining them or scanning them via ultrasound, you realize that a lot of their pain is coming from those soft tissue areas. So I think if you treat those kind of issues as well, where you treat it very comprehensively, meaning soft tissue, joint as well, in someone who still has pretty good range of motion, doesn't have really bad sort of impingement from really severe shoulder OA, they can still do very well. I think on top of that is also for those of us that treat a lot of joints issues as well, we're starting to realize that in folks that have bone marrow lesions within the actual subchondral bone, that treating those issues as well can make more of a difference. I think that may actually make a bigger difference than sometimes even treating the actual joint, because a lot of times that is one of those findings on MRI that really is like an X marks a spot. And treating that, I think, can really take somebody from a average response to someone who could even get really a home run response in terms of pain relief.
Yeah, that is a really interesting point. So, I think what Siddharth was talking about there is when he says a bone marrow lesion, because it's interesting when you use that term, because my wife works in internal medicine and she was like, "What are you talking about, a bone marrow lesion?" And really what we try to do is when we look at an MRI and we see an area within the bone in which there is a lot of swelling, it lights up a different color. And it seems like there does tend to be a great amount of correlation between what a patient feels as painful and finding that appearance on an MRI, for example. So, do you have, Siddharth, in your practice? I mean, do you have experience usually doing injections into the bone, into an area where it has that pattern of swelling as part of your usual practice?
For sure. For subchondral bone, yeah. I don't see a lot of subchondral lesions in shoulders per se, but if it's there, I'll definitely treat it. But I find that in knees, I mean, for knee OA and someone who's had knee OA for more than 10 years, I find that 40-50% of those people will end up having BMLs, bone marrow lesions. And again, anecdotally, in patients where I've treated them, literally just joint and soft tissue, and then a couple of years later, treating joint, soft tissue, and the bone, that they did dramatically better when you treat the bone as well. So it's one of those areas that it's interesting because it's not always described by the radiologist, because I don't think they necessarily see the value in the same way we do now.
Certainly.
And for those of us that are treating those issues, it's like that thing that you're looking for to say, okay, I want to make sure I'm not missing something here. And then that's actually an area where MRI is valuable, where you're not going to see that on ultrasound. You're not going to see that on an X-ray. So the reality is, if it's shoulder osteoarthritis, I would still do an MRI, because I'd want to know if they have that kind of lesion that needs to be treated.
Great. Yeah, and there's been a lot of speculation about whether or not injecting into a bone that looks like that is actually sort of helping to restore the native cell content of what was originally in the bone before something like that appeared. And I really appreciate you saying that you've noticed such a difference in your practice as your practice evolved, because I've talked to other experts in the field at conferences, and I think there was a presentation by Chris Centeno, and it was out at Toby, I think, earlier this year. And he was saying that they had collected a lot of data, but hadn't necessarily, and he may have new data at this point, but had collected a lot of data that hadn't shown necessarily that the intraosseous injections were otherwise superior to those who are not treated that way. But I think it's certainly an evolving part of the field in which people are finding they are having positive outcomes. And so I can appreciate that you seem to have noticed a difference in the way that you help your patients. The other thing that you mentioned was, this is something that radiologists don't comment on. And I did see a video from Interventional Orthopedics Foundation where they were actually talking about, ways in which to read an MRI differently if you are going to offer patients treatments with biologics. And I would echo exactly what you're saying. I think people who are doing procedures like these pretty regularly, they look for things differently on a picture, as opposed to just looking at a report and treating somebody based on that. So really appreciate your dedication in that regard as well. Couple other things in the shoulder that a lot of people seem to have questions about, labrums in particular. I have, in our practice, we do see a lot of younger athletes as kind of well as aging athletes in CrossFit in particular. And we seem to really get a lot of questions about my labral tear and how can I help it heal? Is that something that you see frequently in your practice? And if so, how do you counsel people about it?
Yeah, so I do see a decent amount of labral tears where, meaning they don't have like bad shoulder OA. It is really more of a labral issue and maybe a biceps tendon issue as well. I think the way to approach that is what's really the mechanism of their injury, right? Um, uh, are they stressing their shoulder in a manner where maybe they've strained a couple ligaments that are now putting the shoulder a little bit more unstable, that's now leading to that kind of labral injury? I think especially if you get someone who is still very physically active, doesn't have a lot of pre-existing damage in the shoulder, that's the kind of person where you're injecting not only the labrum, but if you then also treat some of the other shoulder ligaments that actually lead to a shoulder being slightly unstable, that kind of person can do really well. I had a patient today that came in. He's about 2-3 months post just PRP treatment for his labral tear. I think he's like a 16-year-old. And when you take someone like that really has a pretty focused injury like that, that's someone where if you treat not only the labrum under x-ray guidance, but if you then also treat those other shoulder ligaments under ultrasound guidance, you can get an unbelievable result. And you sometimes wonder, is that because you've treated the labrum, or is it really because you've treated all those other soft tissue structures that are leading to that instability? And so it's sometimes hard to really figure that out, but I think leaving out the instability component, I don't think you're going to get as good of a result if you're only treating the labrum. And I would say if you have someone that's doing a lot of overhead physical activity, whether that's at work or exercise, that's the kind of person that if you treat all those other ligamentous instability issues, they can still do incredibly well.
I really appreciate what you said about treating the other ligaments. And in some ways, when I listen to that, it's sort of almost a combination between a sports medicine approach and a prolotherapy approach. I think a lot of people who do prolotherapy, they have that great biomechanical mind where they really think about the other structures that could be involved, that not only did I have an injury, but what were the biomechanical problems or the factors that caused me to develop this injury in the first place, and how do we really address that to keep that from happening again? And I also really enjoyed what you said that, you're like, I don't really know whether treating the labrum itself or some of the other pathology is making a big difference. And one of the questions that I get from a lot of patients is, if you inject PRP into my labrum, will my labrum heal? I mean, do you get asked that question? And if so, how do you answer it?
I think it's important to always focus on outcomes that we know that we can make a difference on, right? In terms of pain and functional improvement. I think those are outcomes that if you give people reasonable expectations of what's actually been proven to occur, I think you can get people on the right framework and you can actually get good results. I think we need to avoid giving unrealistic expectations in terms of taking an injury that may be significant or chronic and saying, we're going to get this to what it was, 3 years ago or 6 months ago. I think that's dangerous from a professional standpoint because you're kind of setting up that individual to really not be satisfied with the result. I think the worst thing that you can have as a professional is you get somebody who's had a really good clinical result in terms of pain and function, and then they're asking, can I repeat the MRI? And you're left there going, well, it'd be interesting. But the reality is really what's important is, are you actually improving clinically, right? Are you actually back to the activities that you were limited from before? Musculoskeletal medicine is, I say this half jokingly, but it is like the dark arts of medicine. My wife is a cardiologist. If someone's had a heart attack, they've had a heart attack, right? Like it's very straightforward. If someone's got cancer, they've got cancer. There may be some subtlety to these diagnoses and all that. But in medicine, somebody comes in with a rotator cuff tear. That may not even be like the cause of their pain. A person who comes in with knee arthritis pain, you look at an x-ray of their other knee and it looks worse. And they don't have any pain in the other one. And so you have to really use, I think, good medical principles of what makes sense. You never want to be telling patients that you can achieve something that is really way beyond what's reported in the literature. But I think if you keep people on the straight path in terms of pain and functional improvement, they'll do well. It's always interesting from the medical standpoint, the professional standpoint, to say, hey, I'd love to see what that image looks like now. Does it look better? That would be interesting. But I don't think maybe necessarily the cost is worth it, especially if someone's doing better. If someone's not doing better, it may be worthwhile to see if something has progressed. But I think just routinely checking it doesn't make sense.
Yeah, we get a lot of questions about how soon after my imaging are you going to be able to tell a difference? And in some cases, we do. We see, some tendons or tendinopathy in which there's a lot of uptake on power Doppler. And so, I kind of talk about what blood vessel formation is like. And after treatments, we can see, differences, especially over time. But especially in regards to the labrum, a lot of times I just tell people, I'm like, look, I don't have an evidence-based study that shows we have second look arthroscopy, meaning a person had a treatment, biologic treatment, and then later on down the road we scoped the shoulder and took a look at the surface of the labrum, or even MRI follow up to necessarily say yes, you are going to see a healed labrum. And I think part of what you said insightfully about whether or not one knee looks worse on an MRI and doesn't hurt somebody, and the X-ray of the other knee looks not so bad, and yet it's very painful. Is there certainly is a difference between the biochemical makeup of what's going on, in a joint or in a musculoskeletal problem, in a structural problem, and I feel like we're at a point, kind of an exciting point, but maybe a point where we don't always maybe fully understand, what is actually the source or the nature of that pain, but at least we have, some evidence and experience to go by to say, well, look, if your goal is to pick up your grandkid, I can get you, we can reliably achieve that goal. Your X-ray may not look better next year, but when it comes to doing the things that are meaningful for you, we can get there. So I really appreciate that. You mentioned one other structure that I think we commonly get questions about or have to address, and that is the biceps tendon. And so, questions about ruptures of the biceps tendon versus tendinopathy versus sometimes, effusions, or we see there's fluid around the biceps tendon, especially on ultrasound. We see that a lot when we're looking for indirect signs, sometimes of rotator cuff tear. To tell us a little bit more about how you see that and how you treat it.
Yeah, I mean, I think in terms of a rotator cuff patient, whether it's an effusion in the bursa or they have a biceps tenosynovitis, I think those are really great subtle things that you can pick up on ultrasound. There's certainly things that I would recommend treating if it's abnormal on ultrasound as well while you're treating somebody. Um, I mean, if someone has a full-on rupture of the biceps tendon, I mean, injecting that's not going to make a lot of sense. You're not going to be able to really heal that, and I'm not sure how much benefit it'll actually have. And I mean, realistically, a lot of those people seem to function fine, even if the tendon's actually ruptured. But I think as a subtle finding that you can pick up on ultrasound and actually lead to more thoroughly treating someone's rotator cuff issue, I mean, that's spot on for sure.
Great. So, are there anything else that you would like to share in regards to, kind of pearls that you've noticed about the shoulder, or common questions or common things that you've noticed in practice when patients are coming to you with questions or concerns that would be good for us to talk about?
Um, I think the big thing is, I think a big takeaway for me over the last 10 years of being involved in these kind of treatments is I really got involved in this with such a highly targeted focus based on ultrasound and orthobiologic treatments like platelets and then bone marrow. It took me a few years to really understand some of the more traditional prolotherapy concepts of biotensegrity and ligaments. And I would really stress to colleagues that that's a really key part of trying to get a good outcome with an orthobiologic treatment. That when that patient comes in with, let's say, supraspinatus, tendinopathy, or a partial tear, definitely start looking at that inferior glenohumeral ligament. That's a huge one to treat. And the classic description of when patients describe their pain, I mean, how often do they end up grabbing in that area in the back of the shoulder? It's so frequent. And it's one of those areas that if you treat and tighten up even just a little bit, it'll help that rotator cuff tear. It'll help preserve the AC joint from getting dinged up. It'll help improve their biomechanics. It fits so well. So, that for me, what I've come to realize is that to really be an expert in this kind of field, regenerative medicine, is that you have to have a really keen understanding of the different types of orthobiologics. You have to have the image guidance from that interventional orthopedics framework, and you have to have that prolotherapy concept in terms of how to treat things. And I think if you do, you can take someone who is a otherwise challenging candidate and really give them a great response, and I mean, realistically, have happy patients. So to me, that's a big thing for me. Focus on image guidance, focus on good principled medicine, focus on those prolotherapy concepts, and utilize the orthobiologic options that are available, and patients can do pretty well.
Dr. Tumbar, I really just want to thank you for your time today. I think what you said was very well said and sophisticated. And, patients who are out there asking questions about, is prolotherapy or is PRP or is bone marrow or stem cell treatment, right for me regarding my musculoskeletal or my orthopedic condition, that's the kind of guy you want to go see. The kind of person who really is very thoughtful, not just about what somebody else has told you is wrong, but does a very thorough investigation and really understands ligament pathology along with the other findings of arthritis and tendons and other supporting structures like the labrum. So thank you so much for taking your time on our show today, A Shoulder to Cry On. That's going to wrap up our episode today. Dr. Tombard, go ahead and tell us again the name of your clinic and maybe your website and how people can find you.
Right. So chicagoarthritis.com is the website. My clinic name is Chicago Arthritis and Regenerative Medicine, located in downtown Chicago. I also have a podcast, the Regenerative Medicine Report. And you can check me out on really all the usual social media sites, LinkedIn, Facebook, Instagram, Twitter.
Thanks so much. We appreciate it, and we appreciate your time. We benefit from sharing the good as well as the bad, so we can figure out how to help people the most around the country. Again, this is an Orthobiologics podcast that's brought to you by Georgia Bone and Joint. You can check us out at georgiaboneandjoint.org, book online conveniently for an appointment, or fly in and we'll pick you up at Atlanta, the busiest airport in the country, and deliver you right here for great treatment.